Tennessee Death Row Dogs, your local dog rescue nonprofit.
My name is Dr Cornwall, and this is the Entrepreneurial Mind. Today our guest is Dr. Stanley Snyder. We'll be back to talk with him after these words from our sponsor.
Talkapolis programming is sponsored by the following. Highland Hills, a multicultural, diversified funeral home supporting the entire Davidson County community. Visit our website at www.highlandhillsfuneralhome.com or call us at 615-650-5555.
Well, welcome to the Entrepreneurial Mind today.
Thank you. Glad
Appreciate
to be
you being here. So you guys have been at this for about 10 years, is that right?
Yeah, it's been 10 years that we've been in our current locations. We actually have been doing vascular surgery and veins I've been doing it for 35 years. So what we've really done is we've moved things out of the hospital setting into the outpatient setting for about 10 years.
So I know with managed care back in the 80s and 90s, there was a big push. Was this sort of part of that whole trend, or was it just advances in the technology that allowed you to do this?
The advance in the technology is what really did it. In the old days, we did what's called a vein stripping. I used to jokingly call that more of a vein ripping.
Yeah.
Because what we did in those days, we made an incision in the groin, you made an incision at the ankle, you put a wire between those two incisions, and you put a ball on the end of it at the ankle and literally pulled about as hard as you could and just ripped the vein out from the ankle to the groin. That caused
a little hard to market that, isn't it?
A little hard to market
Yeah.
it. It's also something you had to have general anesthesia for, obviously.
Right.
So
that was probably more, it wasn't just cosmetic at that point. This is for people who had significant pain and problems with their veins.
And most of what we do now, I would say 80% or more of what we do now is for people who have symptomatic painful varicose veins. We do sclerotherapy, which is a cosmetic procedure, but that's 10 or 15% of our practice. This is still mostly people who have symptomatic discomfort, swelling in the legs, ulcers that won't heal, and big bulging varicoses that just wear you out by the end of the day.
So it's not just women then who are having these kinds of issues, I would assume.
Right. Men actually have bigger veins than women, and because sometimes they're heavier, they do more manual labor, they're lifting heavier things, maybe on their feet more, they actually have bigger veins and more problems than the women. They tend to put up with it a little more because they're not showing off their legs in shorts and that sort of thing. But I'd say 20-25% of our business is probably men, maybe 75% women.
Are they a little bit hesitant to come in and talk about it because there's sort of this old myth that this is an issue that happens with women, or haven't you had that problem?
Well, once upon a time that might have been it, but these days men, they're getting a lot of different procedures done. They're a lot more ladylike than having symptomatic painful veins taken care of.
Right.
So
they have nice shaved legs that they have to show off.
Yeah, exactly. Yeah. So I don't think that's as big a problem now, but they just are more likely to put up with it than ladies are.
So if you're not ripping these veins out anymore, what do you do?
Well, the new technology that, as you say, changed the world a little bit was ways to close the vein down, or we call it ablate the vein, without requiring general anesthesia and without requiring those incisions we talked about. So what we do now is we use an ultrasound guidance. We stick a needle in the vein, we start down below, put a wire under ultrasound guidance up to the groin. Then we exchange that for a laser fiber. Then we take local anesthesia again with ultrasound guidance so that you're making sure you're getting the fluid, the anesthesia around the vein itself. Once you've done that, that does two things. One is it gives you an anesthetic, but two, it sucks up the heat or soaks up the heat that's generated by the laser fiber that we then put in to replace that wire. So we can do it a couple of different ways.
So explain a laser fiber. What is that?
Well, other than telling you it's a laser fiber, you're getting out of my pay grade. But it is, it's laser generated.
Right, you're the guy putting it in my leg.
It's heat generated by the laser.
And so that just burns that vein away?
Right, and actually different lasers have different heat, they get up to different temperatures. One of our lasers gets up to 1,000 degrees in your leg. One of them gets up to about 240 degrees. And so they act in different ways. But what we do is that numbing medicine that I was speaking of, it also has epinephrine in it to vasoconstrict the vein. So what we're trying to do is get the blood out of the vein. So we put the medicine around it, that lets it vasoconstrict, then we put your head down just a little bit to let blood drain out so that hopefully we've got the walls pretty close to proximity, and then when you use the laser, you literally burn the vein shut or weld it shut to seal it off so that it then stays clotted off or burned shut, welded, whatever you call it.
And is it just typically 1 or 2 veins you have to do this on?
Your main vein is your greater saphenous that goes from the groin to the ankle. In the back, when some people have reflux in the back also, you have one that goes from right below the knee to the ankle. That's called the lesser saphenous. This is the greater saphenous. There's also a group of veins that in your leg, people concerned, oh, I'm going to lose my vein. How am I going to get blood back to my heart?
Yeah, I was just going to ask that, yeah.
Well, your blood really comes back through your deep venous system that comes inside the muscles of your leg. And so, you know, when you hear people say they got DVT or got clots in my leg,
right,
or clots that go to your lung, all those come from your deep veins. Your superficial veins don't have much to do with that, so you really don't need them for venous return.
Interesting.
Right.
All right. So the procedure is a couple hours and they're home, or?
Actually, it's much less than that. If all we're going to do is say, let's just say you're going to have reflux. Now, we didn't talk about why you get the problem, the varicose veins. The reason you get it is because of valves that don't close properly.
Right.
So if you stand up and these valves are supposed to close to prevent blood from going the wrong way.
Too much rushes down.
If you get reflux, then all of a sudden you got pressure, increased pressure on the next set of valves, the next set, so then that pressure's looking for somewhere to go.
Right.
So it pops out these veins.
Right.
So that's the etiology of it. And if you don't have massive veins, you just have the reflux, maybe some swelling, the discomfort, and all you're going to do is close that vein down, that's about a 20, 25-minute job.
Really?
And you actually can walk in and walk out with that. Your leg's a little bit sore because you've got this inflammatory response from trying to absorb it to get rid of it. But you can do normal activities the next day.
So you could be back out on the tennis court or the golf course?
Well, actually, normal activities around the house.
Okay.
We tell people you could do those things, but we don't want you to, because what we're trying to do is seal that vein shut. If you get too active, you get your blood pumping and you get everything going and you can open it back up. So we let people walk for exercise after a week. You can do normal things around the house, but as far as I'm going to go take a 3-mile walk or 10-mile walk, they wait a week. And then I like for them to wait 2 weeks before they start doing Zumba and acrobatics and running and tennis and that sort of thing.
So the recovery time in the past was much longer when you had the surgery.
When I started doing the veins years ago, we had people in the hospital 3 or 4 days after doing this vein stripping. Now, they didn't have to be, but we didn't know that. And the worst thing we could do is put them in a bed, flat in bed for several days. They're much better off to be up walking around. So even a vein stripping in the last years, and they haven't done one now probably in 10 years, they need to be up and moving around.
You remember
too.
the last one you did?
No. I didn't quite finish. We were talking about needing the deep veins versus the superficial veins. There's a group of veins that communicate between the superficial and the deep, and they're called perforators. And blood's supposed to go from the superficial to the deep and then return to the heart. Same thing, valves are supposed to let it go this way and not have reflux in it. If those valves are incompetent, well then pressure in your deep system comes out in the superficial system. So we have to close those incompetent perforators with the laser, or, and we haven't mentioned yet, another way that we close veins sometimes with the radio frequency device. It's called a VNUS, it's a venous closure device. And it works the same way, but it generates the heat with radio frequency rather than the laser.
And so why would you pick one or the other?
They were developed by different folks at different times, and some people prefer the VNUS, others prefer the laser. I think the VNUS, because of the way it works, has a little less discomfort, but it also has a little more, it's not quite as efficient in closing it down. So we tend to use both, but we use the laser a lot more because you have a less chance of it opening back up again.
Fascinating stuff. Thanks for coming in today. I appreciate it very much.
Glad to be here.